Hello, my name is Austin Crochetier, and I am an MS4 from UCI Medical School. Today I will be presenting a case titled, Trying to See Through the Fog, How an Atypical Presentation Disguised a Rare Case of CLL and Giant Cell Arteritis. The subject of our case is an elder African-American gentleman with chronic lymphocytic leukemia and atrial fibrillation who presented with acute vision loss. Given this patient's multiple comorbidities and lack of typical findings of giant cell arteritis, the patient was not started on empiric steroids. However, on day 2 of admission, the patient was found to have a central retinal artery occlusion, which was secondary to GCA, confirmed on temporal artery biopsy. This case will demonstrate the dangers of availability bias, it will reinforce the threshold criteria for starting empiric steroids for GCA, and it will showcase a rare pathology report revealing concurrent CLL and GCA. Our case is an 86-year-old African-American male who presented with blurry vision in his left eye for 1 week. He reported progressively worsening vision in both eyes over the last year, but he endorsed an acute vision change while driving the week prior, describing it as a dark fog. He also denied headache, jaw pain, temporal tenderness, or other constitutional symptoms on presentation. His medical history was significant for CLL, hypertension, and a-fib, and he was not taking any medications due to being undoctored for the past year. The patient's vitals in the ED were only significant for an elevated blood pressure up to 169/83, and on physical exam, the only abnormal findings were decreased visual acuity, worse in the left eye, as well as an irregular heart rate due to his a-fib. On labs, the patient had a white blood cell count elevated to 101.4 with 89% lymphocytes consistent with the CLL. The patient's ESR and CRP were also elevated to 105 and 67.9 respectively. At this point, the patient's differential was broad, but certain diagnoses were higher than other. Stroke, either from vasculopathy or a-fib embolus, hypertensive emergency, and worsening glaucoma were higher on the list. Less likely was leukostasis due to CLL. Although the CRP and ESR were elevated, GCA was low on the differential due to the lack of typical symptoms and the fact that the patient's CLL could cause false elevations in those markers. Next, I will briefly discuss the patient's hospital course. On the patient's admit day, brain imaging was negative for stroke, and the patient was admitted for observation, blood pressure control, and management of his CLL. However, on day 2, the patient awoke with complete vision loss in his left eye. Emergency opto evaluation revealed a central retinal artery occlusion. With increased concern for underlying GCA, the patient was started on high-dose steroids. Eventually, the patient underwent a left temporal artery biopsy, and a few days later, a right temporal artery biopsy confirming GCA. In figures 1 and 2 on the poster, we can appreciate two aspects of this patient's case. Figure 1 demonstrates his EKG on admission revealing a chronic a-fib, although his echo was negative for a cardiac source of embolus. Figure 2 is an optic nerve analysis performed after the patient lost his vision, demonstrating a central retinal artery occlusion, supported by a cup-to-disc ratio of 0.95 when normal is less than 0.3. Next, I want to highlight the interesting pathology report in this case. After multiple reads by a variety of pathologists, it was confirmed that both CLL B cells and GCA T cell infiltrates were seen in the wall of the artery, seen in Figure 3A. Figure 3B shows a giant cell, and Figure 3C shows destruction of the internal elastic lamina, both histopathologic features of GCA. This case has 3 important discussion points. First, availability bias. Availability bias is a cognitive bias that affects physicians where we tend to drive our differentials towards more common diagnoses, even though there are clues that point in other directions. In this case, it was a natural inclination of the team to consider stroke in a patient with signs of vascular disease and a-fib, but it caused them to ignore the elevated CRP and ESR, which they attribute to the CLL. Second point, threshold criteria to initiate empiric steroids in GCA. As internists, we are trained to look for the classic signs of GCA, such as transient vision loss, jaw claudication, and constitutional symptoms. This patient did not have those features, so a GCA diagnosis was set aside. Yet given the outcome of this patient's care, it becomes essential that we remind ourselves some of the most important signs of GCA so we will know to start steroids, despite the downsides, in the future. Some signs of GCA in a patient over 50 years old include new headache and new visual disturbance, jaw claudication, constitutional symptoms, and high ESR and CRP. Third point, CLL and GCA can occur concurrently in a temporal artery biopsy. This phenomenon is very rare. In one database study from 1950 to 1994, only 5 CLL patients developed subsequent GCA, and only 3 of those patients had GCA confirmed on biopsy. It's theorized that the T-cell-driven process of GCA selects against the B cells in CLL, but this case stands as a counterpoint to that theory. In conclusion, as internists, we must be cognizant of availability bias and maintain broad differentials despite the universality of certain diagnoses like stroke, because if we don't, we could miss a case of GCA in a patient with enough signs to meet threshold criteria, leaving the patient blind. Finally, we offer this pathology report as an interesting addition to the literature on GCA and CLL. Thanks for your